Imagine blood moving not like a river, but like a pressure washer. That constant, heavy mechanical strain against the arterial walls is the baseline reality for millions suffering from resistant hypertension. This graphic maps out a clinical bottleneck. We're looking at a trial cohort of 794 patients trapped in this high-pressure state. Despite swallowing 2 to 3 daily medications, including diuretics, their average systolic blood pressure remains dangerously elevated at 149 millimeters of mercury. The driver behind this massive fluid and sodium retention usually originates down in the kidneys, controlled by a specific hormone, aldosterone. This comparative chart tracks how we typically fight back. The standard therapy, spironolactone, acts as a biological shield over cellular receptors. It forces pressure down by 10 to 16 points, but it exacts a high collateral cost. Roughly 6% of men develop breast tissue, and 2% of patients stop the drug entirely. If we move down the list of alternative drugs, the returns diminish. Finerenone yields about a 7-point drop. Amiloride sits between 5 and 7 points. Standard beta and alpha blockers buy us around 5 points, but they often arrive bundled with chronic fatigue and dizzy spells. Even mechanical interventions hit a wall. Renal denervation, a surgical procedure designed to calm overactive nerves, caps out around an 8.5-point reduction. Every tool in the current medical arsenal has a hard ceiling. Many fall short on lowering pressure, and others trigger side effects patients can't tolerate. This happens because they are purely defensive therapies. They try to block aldosterone at the receptor long after the hormone has already flooded the system. Baxdrostat, marketed as Baxdrostat, takes a different geographic approach. Instead of waiting defensively at the receptor, it travels upstream directly to the production site, the adrenal gland. Here, it operates as an aldosterone synthase inhibitor. Rather than blocking the hormone, it severs the chemical pathway that manufactures it. It shuts down the factory. To test this mechanism in humans, researchers launched the Phase 3 BaxHTN trial. The graphic details the patient makeup, mostly individuals in their late 50s, roughly 37% female. Notice this highlighted section. Nearly 3/4 were clinically classified with true, verifiable resistant hypertension. Researchers stress-tested the mechanism against a high-stakes, real-world population that had already exhausted traditional medical options. Over 12 weeks, the 1 milligram dose line drops 14.5 millimeters absolute. The 2 milligram dose pushes further. Pressure falls 15.7 points, a 9.8-point placebo-adjusted drop. This bar chart shows reality. 40% on the higher dose achieved control, below 130, compared to under 19% on placebo. To prove the drug was actually doing the work, researchers ran a withdrawal phase. When they stopped the medication, patient pressure rebounded by 1.4 points. But for those who stayed on the 2 milligram dose, pressure dropped another 3.7 points. Shutting down aldosterone synthesis results in a pressure reduction that rivals the most potent existing treatments. There is a physiological cost to this approach. Aldosterone regulates electrolytes. When you halt its production, you force the body to alter how it processes sodium and potassium at the cellular level. This risk matrix shows exactly what that looks like. The primary concern is hyperkalemia, high potassium. In the 2 milligram group, 11.1% of patients crossed the threshold, compared to 6.1% on the lower dose and near zero for the placebo. Zooming in on the severe cases, where potassium exceeds 6.0 millimoles per liter, the 2 milligram group hit 3%. That complication forced a 1.5% discontinuation rate in the trial. The expanded data highlights the secondary metrics. We see hyponatremia, low sodium requiring medical intervention, at 2.3%. Serious adverse events sat at 3.4%, slightly higher than the placebo's 2.7%.